Welcome to the Walk in the Park podcast, the official podcast of the Lead Up Task Force of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. In Season 1, we will be taking a look behind the curtain of the C-suite, sitting down with individual CEO, CMO, CFO, CNO, and COOs of a diverse range of physician practices and hospital systems. Please remember to hit the like button and subscribe to stay up to date on the latest episodes. Enjoy the show.
Welcome to the inaugural episode of the Walk in the Park podcast. The purpose of the Lead Up Task Force is to empower SAGES members to advocate for their patients and their profession, to educate SAGES members on strategies for effective interaction with internal and external healthcare partners, and to encourage SAGES membership to have a voice in leading positive change. This podcast series is one way the Lead Up Task Force is providing insight and guidance to all SAGES members on how to interact with the different parts of their surgical environment in order to have a positive impact. Each session will have a theme, a different group that we will interview and investigate to pull back the curtain so that all SAGES members can understand why these groups approach issues the way they do and how they view these issues when engaging with their clinicians. And with that, we will start with self-introductions for the co-hosts for Season 1, the C-Suite. My name is Dr. Ross Goldberg from Miami, Florida. I am the chair of the Lead Up Task Force, and I'm excited for the opportunity to bring this podcast to our SAGES members so they can learn more about what our hospital's executive leaders think about our issues.
And I'm Dr. Kevin L. Hayek from Cleveland, Ohio. You may know me from various podcasts such as SAGES Stories, the official podcast for SAGES, and likely the reason I was tapped to help launching this one. That, and I've also been told that I have a face for radio. My goal for helping launch the first season of Walk in the Park is to represent the voice of the practicing surgeon who wants to build some skills in leading up within their organization.
And I'm Dr. Julia Amundson, a current chief resident at the University of Chicago, joining in to represent the voices of those who have minimal experience interacting with their institutional leadership and are looking to get involved early on in their career. For our inaugural episode, we are thrilled to welcome an inspirational leader and friend in SAGES, Dr. Paresh Shah. Since 2023, Dr. Shah has been Group Senior Vice President and Chief Operating Officer at NewYork-Presbyterian Weill Cornell Medical Center. Prior to that, he served in multiple leadership roles, including Vice Chair of Quality and Innovation, Chief of the Division of General Surgery, and Surgeon-in-Chief at NYU Langone Hospital. His training background includes a general surgery residency at the Lahey Clinic Medical Center, after which he had an illustrious clinical career with a predominant focus on minimally invasive gastrointestinal disorders, focusing even more specifically on malignancies. He pioneered and refined laparoscopic pancreatic and gastric surgery, including one of the largest experiences in laparoscopic Whipples in the country. Needless to say, with an introduction like this, his list of accolades and awards goes on and on. We are very grateful that he's agreed to share his wisdom with us for this new SAGES initiative. Welcome to the show, Dr. Shah.
Thank you, Julia. Thank you, Ross and Kevin. Actually, real pleasure to be here with you, and I'm really honored to have been asked to participate in this and to be part of the inaugural podcast. So thanks very much for having me.
Well, it was no doubt that you were going to be the inaugural guest, and just hearing that introduction and having a quick glimpse into your leadership, we know that you are going to just pour out some wisdom for our SAGES members. But before we start kind of peppering you, because we will start that fairly soon, why don't you just tell us a little bit about yourself, your background, where you're from, and kind of what led you to your current position?
Thanks, Kevin. So I'll start. I'm an immigrant. I was born in India to a family of very modest means, and came here in the 1970s into elementary school. Learned English as my third language in Sheepshead Bay, Brooklyn, and so worked pretty hard not only to learn English, but to make sure that it didn't come with a Brooklyn accent. Sometimes
very important.
I'll
Very important.
I'll still slip back into it from time to time. But it was actually a great experience growing up in New York City and Brooklyn. And I have to call out my alma mater, which was Stuyvesant High School, which was actually one of the most formative times of my life. It was a phenomenal place to learn and be surrounded by hundreds of people much smarter than me. And that was one of the best parts of it. And that's where I got to really appreciate being around really smart people that were capable and accomplished. Through university, medical school, and I actually went to medical school thinking that I was going to have a career in health policy and thinking that I was going to work in administration right from the beginning. I'll do 3 years of medicine or peds residency, then go and get my MPH and go directly back into policy. When I was a medical student, I was very active in AMSA and the AMA MSS, and was actually the national coordinator for legislative affairs for a couple of years. But then I got to medical school, and the only thing I thought I would ever want to be was a surgeon. The first surgical rotation, I felt at home. That was it. And like all of us, went through a couple of different things that I wanted to do in surgery, but eventually really got enamored by and fell in love with the innovation that came with laparoscopy and minimally invasive surgery. I was very fortunate to be coming through at a time when it had just entered the world of general surgery. And so got to see it at its infancy, got to participate in it at its infancy. And then when I got to the Leahy Clinic, and as part of a young faculty there, my background in health IT, which we didn't get into, and we can later if desired, although I doubt it, led me to some opportunities in leadership and administration. So even as a very young attending, and this is now, gosh, I don't want to date myself, but 25 years ago or more, I got an opportunity chairing a health IT committee and then becoming the first CMIO at the Leahy Clinic. So got to work with physician leaders and physician executives to understand how a health system worked and how I could contribute to it at the same time while building a clinical practice and a research portfolio and a research lab and getting to do all of those things. And that just continued and it carried on. So I was able to develop clinical roles, administrative roles, and academic roles in parallel and develop leadership skills through those, leadership experience through those, and then build on that with coursework, with formal structured work, either outside or within my institution, to help acquire the skills that we don't get in medical school, that we don't get in residency, and frankly, we don't even get in practice. And then over time, use those to help to continue to develop new skills and new opportunities. And ironically, life coming full circle, I ended up in administration. And I ended up continuing to work in health policy for years, whether it was representing SAGES at the AMA CPT editorial panel or at the House of Delegates for the AMA or at the American College of Surgeons or any other forum. So in retrospect, what looks like a straight line was in fact remarkably circuitous, incredibly roller coasterish, but here I am today, and I'm delighted to be with you guys and talk some more about it.
Well, that's a great start, and actually it goes right into let's talk about where you are now. So let's talk about the system you're in and your role as Chief Operating Officer. Just give us a little more insight to that,
Sure. So, as you said in the introduction, I've been in this role for a little under 2 years now. And I am the Chief Operating Officer for the Weill Cornell division of NewYork-Presbyterian Health System. So this is an 11 hospital health system that is one of the larger ones, larger academic health systems in the country. We're unique in that we have 2 Ivy League medical schools as part of our health system, both Columbia and Cornell. And our hospitals are divided almost equally between the two schools. And I have the responsibility for all of the hospitals in the Weill Cornell division. So that includes the main Weill Cornell Medical Center, the Alexander Cohen Hospital for Women and Children's, the David H. Koch Center, our Lower Manhattan Hospital, and in a matrix relationship with our Brooklyn Methodist campus and our Westchester Behavioral Health campus. So all in, it's a little over 1,500 beds across each of those campuses, about just under 95 operating rooms across those areas. And I'm responsible for all clinical operations, all hospital operations, strategy, and maintaining the bottom line, improving quality. And then most importantly, in my eyes, working directly with the faculty of the Weill Cornell Medical School that represents all of our physicians, as well as the voluntary physicians that are in the community, whether it's in Manhattan or Brooklyn or Queens, and making it a truly integrated enterprise. So where we've got two discrete financial entities, two discrete boards. The Weill Cornell Medical School is part of Cornell University and is completely part of that. And our physician organization, our faculty practice, is actually owned by the medical school, not by the health system. And so it is in many ways the most traditional academic medical center model. But having both universities gives us an interesting opportunity to create some synergies where there is opportunity for that, but still allow both schools and both faculties to flourish independently.
It sounds like a pretty unique, amazing experience to work in that role. How would you describe your personal leadership philosophy and how you have approached being in this role?
You know, that's a great question, Julia. It's one of the toughest ones to answer. There's a lot of cliches around leadership style and leadership strategy. And if you read enough books, and I think most of you will have read some, and you'll probably read more, there's lots of descriptors out there: transactional leaders, inspirational leaders, transformational leaders, servant leaders. My experience is that you are the leader that you have to be for the situation that you're in and for the job that you have. There are certain qualities as a leader that I think are really important, but I don't really ascribe to any one of those stereotypical classifications. The most important thing that a leader can do is to inspire people. And you do that by trust. You build trust by demonstrating vulnerability and honesty and transparency. Doesn't mean that you can share everything with everyone, but you always need to be honest. You need to be true to yourself, and you need to be consistent. And that helps to build that trust and then empower people to do what they're best at. I started off talking about my time at Stuyvesant being formative because I was surrounded by really smart people. A leader, in my mind, isn't the person that knows everything. It's the person that knows how to get everything. And what that means is how to help the people that you're working with work to the best of their ability and drive towards that shared goal. So yes, creating a shared goal absolutely matters, but it's really about getting people to work at their best because they want to do it for themselves, the organization as a collective, and that's how you drive forward.
That's an awesome. It's a great answer. We're gonna have some tough ones for you, so you got to be on your toes here. So, what is the job description of a COO, and what motivated you to apply for such a role, especially given your successful and established surgical practice in the best field of surgery, HPB? I know I'm not biased at all, but what was the motivation there to sort of quote unquote go to the dark side?
Yeah, it's a great question. So I'll start with acknowledging that it really isn't the dark side. Why do I believe that?
Well, that's part of what we're trying to dispel here, but it's clearly what you've heard a number of times, right?
I've heard it. Oh, sure. I was probably guilty of saying it. I mean, let's be honest, right? As practicing surgeons, we're always thinking about the hospital administrator, the health system administrator, the medical school leaders as being barriers to our vision, barriers to our success. And it's unfortunate because I think it's true that in certain situations that was probably true. But I will share with you, in the overwhelming majority, that's really not the case, right? You've got to start with the presumption that if we're in this business, whether you're a hospital administrator, a surgeon, an internist, a nurse, anyone on the delivery side of the equation, we're all in it for the same reason. We're trying to take care of patients. Where things get lost and where some of that dark side stereotype comes in is, well, you're blocking my ability to take care of my patients the way I want to or the way I think is best. And you're imposing any other constraint on that. But you got to think about why is that constraint there? And is there actually even a constraint there? And maybe we'll circle back to that because I'm not answering the question you started with. Let me go back to that, Kevin. What is it about the job description that made me apply for it or made me want to seek it out? COOs in general, you're responsible for operations, which sounds really mundane and can actually be a little bit boring because in the job description, some of the aspirational stuff is exciting. Strategy, understanding how to set policy, creating opportunities for collaboration, innovation, making sure we're performing at the highest possible quality. And those sound really good. But at the end of the day, it's also about making sure that the floors are cleaned, making sure the supplies arrive on time, having contingency plans for when they don't, managing labor unions, understanding what happens when the toilet explodes in a patient's bathroom and ends up flooding 4 floors below. It's all of the things that you don't actually think about. Cafeteria staff, making sure that there's food available at night for the residents on call, and how you're going to pay for that food for the residents on call and not count it as a benefit. All of these nuances come in. So it's really the totality of what it takes to keep the hospital running, doing what it does. I found that actually really exciting. It was fascinating to me. And part of it was because I had spent the last 5 or 6 years doing that in detail for Periop, for just all of the ORs. And so I had a pretty good sense of what it took to run an OR operation of 150 rooms across 5 hospitals. And I thought it'd be interesting to take that on for 5 hospitals and everything that goes inside them. But in the
you're a bit of a glutton for punishment, is what you're saying.
That's probably true. I can't deny that. I like working without question. But I also wanted to do it in an academic setting, right? I could easily have looked at similar opportunities in either a for-profit system or another not-for-profit but not academic system. And they're all good jobs and they're all really important things to do. For me, being in academic medicine my entire career, it was important to continue that journey in an intensely academic environment. So it doesn't get any more ivory tower than Cornell and Columbia, but that's where we are. Was I ready to leave operating is the really interesting question. So and Kevin, you know this, I think Ross, you do too. I loved operating. I absolutely love operating. I love taking care of my patients. I love teaching the residents and the fellows, but I also just love the technical surgery. I had also gotten to a point where I felt like I had climbed most of the mountains there were to climb technically. And I don't mean this to sound immodest in any way. It's just you get to a certain point. I had been really fortunate to have been able to develop certain techniques, develop new operations. I did therapeutic endoscopy as well as HPV surgery, and it was all so much fun. And it was fun to do, and I loved the emotional bond with my patients and the gratification of taking care of them. But I wasn't getting the intellectual stimulation or the challenge anymore from it. And so I was looking for more challenges. And for me, and this is not to say that it's the same for everybody, but for me, I was looking for more challenges. And going into health system management, going into health system operations, dealing with the political questions of how to manage a health system in the state and in the federal environment, as well as the clinical program, as well as the academic program. These were new challenges that I was ready for. I had not anticipated going from 100 to 0 in surgical activity as quickly as this transition necessitated. I had a master plan, like we all do, that I was going to spend the next 5 years gradually doing less and less surgical volume as I did more and more management administration. But then the opportunity arises and a decision had to be made. And so part of the challenge in my role here and at this organization, moving to this, it was very clear, this is not a job where I could have a clinical practice and do this job. In some scenarios, you can. And in fact, I've had colleagues in other institutions who've been able to maintain a clinical practice of some degree while they're in this level of C-suite role. If you're in emergency medicine, if you're a cardiologist, even in certain branches of surgery, if the acuity of what you're doing is prescribed enough, then you can still maintain a little bit of a clinical presence. It's really hard to do Whipples and gastrectomies and hepatectomies and do this job. It's impossible. In fact, I think you would do both sides a significant disservice. You do your patients a disservice, and you do the responsibility to the hospital and everyone in it a disservice. And so this needed to be a clean break for me. So my last operation was, well, in 3 weeks, it'll be 2 years. And it was a subtotal pancreatectomy, and I'm still in touch with the patient, and she's doing great, which I'm delighted.
Awesome. That's awesome.
And it's, again, you remember the last one, right? It's always, you remember exactly. I'm sure you can walk us through the whole thing. We don't have time for that, but yes, I know we'd all love to go through that technical stuff, but there is a reason why we're here. And while we all love to talk about it, I want to focus more on kind of this whole journey you've been talking about. So I'm sure you're aware we had a retreat recently. I know this sounds familiar. And at this retreat, really, we're brainstorming ideas to help our members kind of lead up in their practices and organization, the whole concept of this task force. And one comment that came up was that during our training, we've all been brainwashed as surgeons to say that we shouldn't be at the table, right? We don't need to be there. We should be in the OR. That's where we should be. You obviously have ignored that, brainwashing, if you will. It's not only made it to the table, you're kind of one of the leaders at the table now. So we've heard kind of your whole journey. You were touching on it as you can kind of go through your story and then how you got this role as COO. But what have you learned in this whole journey to let you play that role, to go against the grain, if you will, like the dark side we talked about? You went against the role saying, we can do this. I can be at the table. I can lead the table. What have you learned on the whole journey?
So it's a great question, Ross. I'll start with saying, the old adage is if you're not at the table, you're on the table. And that's true in most things in life, right? If you're not on the table, if you're not at the table, you're on the menu. But here's the real reality. As I was alluding to earlier, we absolutely not only need to be at the table, but we're actually wanted at the table. The most fundamental misconception that surgeons and frankly all clinicians have is that health system leadership, hospital leadership, school leadership don't want to know what you want to think or what you want to say. In fact, it's exactly the opposite. It goes back to what I was saying earlier. Assume collective good intent. And that's absolutely true. Nobody's in this business if they don't want to take care of patients. Nobody's in this business if they don't want to take care of each other. That's why we're here. And so start with the assumption that whoever's sitting at that table, whether it's the CEO, the COO, the dean, the department chair, whoever it is, they have at some level shared goals with you. Then the question is, where they're not necessarily shared or at least not well understood, how do you get to that understanding? And so there are going to be individuals who may not want to hear what you as an individual think. Take the individual anecdote out of play, but think about the system as a whole. They're always going to want to know. Part of the challenge is, how do you communicate what you're thinking? How do you communicate what's important to you? And then how do you put it in the context that makes it relevant to the person that you're talking to? Making sure that they understand how what they're talking about is relevant to you as well. I think it's really important to first accept that your opinion as a surgeon, even if you're a chief resident, even if you're a fifth-year attending, if you're on the trauma service, if you're running HPB, if you're just another rank and file frontline surgeon, what happens to you has real impact and has value. And your ability to contribute from that experience to leadership is actually really important. And speaking for myself, in each of my different roles, I've always wanted to know. But I'm not alone in this. I'm certainly not an exception to this. All of my colleagues absolutely have wanted to know what the surgeons think. And not just what do they think about which instrument do they want. That's certainly part of it. But if all you're concerned about as a surgeon is, do I have the stapler I want? That's a very transactional question. And it's going to be handled in a transactional way. It's going to be, yes, you can have it, or no, you can't. If you're lucky and you're able to have a dialogue about it, you'll get, yes, you can have it, and this is why, or no, you can't, and this is why. And that's great, because at least it helps you to understand the why, which I think is a really important piece in any dialogue, is to understand the why. And so as we think about and as we talk about how to talk and how to lead up, one of the themes that really becomes important is understanding the why, being able to express your why, and being receptive to listening and understanding the other person's why.
Fantastic.
A little bit taking a different bent to the conversation here, but as a resident member of SAGES, representing the younger surgeons in the group, we don't receive any formal education or training about hospital administration, the structure of organizations on a broader level, or how we as individuals interface with those groups. And curious what you would recommend in terms of resources for trainees and younger surgeons who are just starting on their journey to have a little bit better insight into what is behind the curtain.
Julia, that is such a great question. Let me start by telling you that we have collectively, as an establishment, failed ourselves for the last 50, 100 years because we haven't taught this. And we're getting better in pockets, in certain places, but not getting better enough. I'll share with you one of the things I do since taking on this role here is that I actually meet with the chief residents of every specialty every quarter to talk about the challenges of running the health system and help them understand how they fit into that. But that's still, that's a bit Socratic, but it's not structured and formal in the way I think it really needs to be. Ideally, every medical school curriculum in the country would actually build this into their medical school curriculum so that regardless of the specialty of the physician, they understand the system that they're going to work in and be able to relate to how they will interface with that system, whether they're a surgeon or a dermatologist or a gynecologist or a family practitioner. After that, residency programs absolutely need to do it. So I got to serve as a residency program director for the better part of 8 years, and building a formal structure into that curriculum was actually really important. And there's lots of pieces to it. There's policy, there's systems, and there's the academics, if you're going to stay in academic medicine. And recognize that most physicians don't stay in academic medicine. But most physicians are going to be employed. And so what we need to do and we can have a whole discussion around whether that's right or wrong, good or bad. It doesn't really matter. The fact is that as of today, in 2024, 70% of physicians around the country are in an employed model of one type or another. And moving forward, the overwhelming majority of graduates from every training program across specialties are planning to be employed. And so that's just a reality of what practice is going to be like. So we should be preparing you to do that. What are resources you can use today? And I think this is to your question. There are, as it turns out, a lot of resources that are very scattered, and they're small pieces. It's not easy to collect that information right now as a trainee, to find all of the different pieces you want to and need, but you can get them in different places. Certainly the American College of Surgeons has resources, SAGES has resources. Asking questions is probably the single best way right now. And I would challenge everyone who's going to listen to this podcast, every resident who may listen to this, go find your hospital COO. Tell them I sent you and say, I'd like to understand how this place works. I'd like to understand how this works and how others work. Can you help me? I guarantee you will get a receptive audience and they will make time to talk to you about it. Because there's no other way to find out that. One of the realities is, if you've seen one academic healthcare system, you've seen one academic healthcare system. Everyone is different, like families in their unique way. But there are certain themes that are the same across. And if you're not in an academic healthcare system, but you're in any other system, you absolutely want to ask questions. One of the things that I think people make a big mistake about doing is they don't ask enough questions. They listen. They're afraid to ask a question because they don't want to sound ignorant or they don't want to sound stupid. And then they listen and they just nod in agreement and they figure, okay, over the next year, I'll absorb by osmosis what the people around me are doing. But what they don't realize is that most of the people around them have tried to do exactly the same thing, which is absorbed by osmosis, and their impressions of what the interactions are and what the rules are and how things work are actually flawed and wrong. I'll give you a very simple example of that. Earlier today, I had a meeting with one of our department chairs. And this department chair is a department chair with their division administrator, was struggling to understand why we weren't ready to support certain programs that they wanted to start and invest in those programs from the hospital side together with the school side. And we were talking about how certain things are critically important to do from a mission perspective, but don't generate any revenue or any margin on the hospital side, or in fact, are a loss leader on the hospital side. And the chair didn't know what those were. And it was an opportunity to have that dialogue and talk about, okay, here's the list of things that we do in this department. And here are the things that we can actually generate a margin on. Here are the things that we don't generate any margin on. And here are the things that we actively lose a lot of money doing. And we need to do all three. But we have to think about how we balance the three that we do. And as the chair, I need your help in achieving that balance. And that's how we're going to help figure out what we can contribute to. Because the things that we make a margin on are going to help me support the things that we actively lose money on. And as a quaternary academic medical center, we absolutely have to do things that we lose money on. Now, that's not true for a for-profit hospital that doesn't have the same mission. They can make a choice and say, we're not going to do anything that we lose money on. It's a perfectly reasonable choice to make. It's not part of their mission. That's okay. But if you're working in that environment, then you need to understand that that's their mission. You need to understand that that's going to be a factor that makes decisions for them. If you're in a health system that is run by a divinity-based group or a faith-based group, then they're going to have certain decisions they make and certain things they do based on their mission. And whether you agree with it or disagree with it, that's going to be the constraint that you're in. And so you have to be willing to ask questions to really understand what you're dealing with and what you're managing.
I think that's a great point. I have a next question, but I think the corollary you just gave, though, and I flip it, is that, we all talk about how we get, frustrated at times that our patients will do the same thing to us. They will nod and defer. If they don't understand, they won't ask the question. So why are we now mimicking that same behavior that we feel the other end of? And so I think that's a great way to look at it, as ask questions.
Yeah.
Don't be afraid to. You're not going to get in trouble.
Yeah, I think I can't emphasize that enough. Never be afraid to ask a question. My 3 favorite words, and I tell this to my management team every week. My 3 favorite words in the English language after I love you are I don't know. And I try
So
to
then when you say, do you love me? And they say, I don't know, is that those like kind of 1 and 2 right there?
That's great.
Those are your 6 favorite words.
You
all
wait
of
right
them.
there. You've got it all right there.
Do you love you? I don't know.
I didn't say I said I love you are my 3 favorite words, followed by I don't know. But do you
All right.
love, that's a setup.
That's
So off love asking questions, let's ask another one, shall we? So going back to the that silly retreat I mentioned before, right? But there was one interesting statistic that came out that, talk to our COO, we're talking about margins, we're talking about value.
Yeah.
So, one statistic that came out that said that every dollar brought in to a healthcare system by a physician actually translates to about $3 to $4 for the system itself. Two-part question. First, does that kind of track what you see as a COO in your system? And if so, or even if not, how do you share that kind of information with your employees? Because again, there's a whole big discussion about value right now, right? How do we define it, quantify it? And that's been a debate you and I both know for a long time. So I'm asking you, Dr. COO,
Yeah.
talk to me more about value.
So great question. I'm going to answer the first question and then talk about the second. So it's a little bit misleading to say that for every dollar a physician brings to the organization gets $3 or $4 out. Actually, it isn't really that simple, and you can't boil it down that way. It also does lead into the discussion of downstream, right? So this is one of the things that everybody talks about, and as the COO, I get this a lot. Every doctor, every department, every division wants credit for all of their downstream. Well, it's one stream. No matter how many tributaries you want to assign to it, it's still really only just one stream. And at the end of the day, there's a bottom line for everybody. And what's true in our system today is that the facilities, the hospitals, the health systems, generally can make more margin on the delivery of care than the providers themselves do. Pro fee revenue versus facility fee revenue. And so as we talk about integrated health systems, as we talk about vertical integration, it's a way to distribute that margin across all of the participants in that provider environment. But there is still just a limited margin at the end of the day. Value is a much trickier equation. How do you define value? So in an economic model, value is quality over cost. It's a simple quotient, but it's a lot more complicated than that simple quotient. And can you improve either one? You can improve value by decreasing cost. You can improve value by increasing quality. You can try to do both, and sometimes you can. You can also add cost and disproportionately improve quality. And that's a reasonable way to generate value, but it's a hard one because adding cost is always more difficult to do when you're in a margin-constrained environment. And every healthcare delivery organization is a margin-constrained environment. In the United States today, that's just a reality. We don't have margins like the software industry. We don't have 30, 40, 50, 60% gross margins. The average hospital margin in the United States is 1.5%. That's it. Okay, no matter how big the organization. Really, really well-run organizations with good payer mixes and in good areas may run a 5 or 6% margin.
So it's basically restaurant type industry numbers.
Right. That's right. And we're constrained because our revenues are capped, and we don't necessarily always get to decide our revenues. But in that, we do want to create value. And Ross, I think going back to your question, how does a surgeon add value where they are, right? There's actually a lot of ways you add value. And bringing in more patients is actually just one part of it. And in many cases, it may not even be the biggest part. Certainly, having enough clinical volume to be productive is really important for you as an individual surgeon as well. But then you think about, how am I adding value to the organization as a whole, to my practice? And one of the challenges that surgeons have to overcome, and this is true whether you're in private practice, part of an academic department, or just employed, is if it's always defined by just what happens for you, then by definition, it's never going to be value. We've got to think holistically. We've got to think more expansively about how we do things. We add value by improving quality. We add value by reducing cost. We add value by finding opportunities to improve the employee experience, the patient experience, the physician experience across the board. All of that adds value. And it does matter how you do it. And it can actually dramatically increase your value as a surgeon as part of that organization. Whether you're in private practice and splitting across 4 hospitals, or you're an employed surgeon working for a single entity, or you're an academic practice, adding value to what you participate in is absolutely achievable. And it isn't constrained by any one thing. There's a lot of different ways to add value and insight. Surgeons, I've known a lot of surgeons who are remarkably empathetic and who are able to actually not just demonstrate that empathy, but teach others how to be empathetic and provide that view to the patient experience and help have that inform the patient experience across the way. That's tremendously valuable. It isn't as simple as, oh, don't use this instrument and use this one because it's $20 less. There's value there too, without a doubt. But in many ways, that kind of stuff is, that's the jacks are better to ante. That's the transactional stuff. That's not where the real value lies.
Thank you for that. It's very insightful. For the average surgeon who is going to communicate with their C-suite, they're trying to figure out the best way to be an effective communicator, how to demonstrate their value, how to express their why. Any specific tips and tricks you would have?
Sure. So first, you don't have to communicate with the C-suite to get it. The first misconception is that if you don't talk to the COO or the CEO, nothing's going to happen. And that's really not true. In most well-run organizations, if you need to escalate to the CEO or CEO to get something done, you got a real problem in the organization. And so when you think about how are you trying to get something done, understand what is it that you're trying to get done and who do you need to work with to get it done. And if it's a reasonably well-run organization, it should almost never be someone in the C-suite. It doesn't mean you can't go to them. It doesn't mean you shouldn't talk to them. And you should absolutely find them and have a relationship with them. But that's not for the sake of getting something done. It's because you want to know who they are, and you want them to know who you are. But you should be able to find the right resource to be able to accomplish what you need. And then it's a matter of scope and scale. So let's take some specific examples, Julia. If you, I keep going back to, you're a surgeon and you know what, I want to try this new instrument. Okay. You really need to get in touch with the COO to get that new instrument in? No, you need to talk to the medical director of the operating room or to the person in periop business operations. You can call Ross, say, hey, I want to try this. And Ross will say, hey, in our organization, we have a new product request process and we formalized it. Or in another organization, they may say, sure, Dr. Emerson, tell me what you want. Talk to the rep and we'll get it in. It's going to be completely different in each organization. So understand where you are and then how you figure out who to talk to get it. If you want to do something, let's say a little more involved, like, hey, I really want to start an EROS clinical pathway for elective colon surgery, for elective pancreatic surgery. How do I do that? And if you don't know how to do that, then first you start by talking to your colleagues in your department. You talk to your department leadership. And it's always going to involve the hospital leadership as well. So now it's, I've got an idea, and you run it up the flagpole and you keep escalating up to the people that can help you get there. A big part of that, no matter who your audience is, goes back to the question of the why. What's the why? And so practicing being able to describe the why is a really important skill set to develop. And it is exactly that. It's a skill set. It's something you can practice. It's not the same as an elevator pitch. And I think it's an important distinction to draw, right? Elevator pitches are for venture capitalists and for PE firms. Elevator pitches are for startups, and that's great, and they have a lot of value. But the why of understanding an achievement that you want to get to, or a project you want to get to, or just an understanding of a pain point that you have is an important thing to develop. It's being able to explain it, and some of the things that I find really effective. People act on facts, but they respond to stories. So start with stories. Stories are incredibly powerful, whether it's a personal story that explains your perspective, a patient story, or an experience. Stories are illustrative, they're emotional, and that emotional tie will bring the person in, and then you have to follow it with facts. Stories alone will never close the deal, but a story is a great way to be able to illustrate the why, and then have the facts to go with it that then flesh out the story, and then have a plan. I think it's important. Now, to the extent that you can, if your challenge is that you've identified a problem that you're feeling personally, and this is true for, I think, many surgeons, they feel like, okay, I'm living this problem, but no one's listening to me. The first question I ask when someone says that is, well, who have you said it to? And if the only person that you said it to is the person sitting next to you in the surgeon's lounge over a cup of coffee, well, yeah, you're right. They're not really listening to you because they're living the same problem. So who have you told the problem to be able to respond to it? And so if the issue is, I have a problem, I need someone to help me solve it, or I need someone to solve it for me, then make sure you're finding the right person to actually help you solve it. If the issue is that you want to do something different, you want to do something new, then again, it's who's the right person to get to help you execute on that. And it's going to be different in each environment. So there's no one size fits all, but that's where it requires learning the environment you're in, learning the players who are in it, and then being able to figure out who's got what in their portfolio and how do you help them help you in getting there.
I want to say for Paresh, your first example, yeah, reuse me every day. I get that call at least once a day, every day asking for things. So yes, he's right. It
Use your
never
periop.
stopped there.
I mean, this is, I think Julia and Ross would agree, this is all gold, and it pretty clear why we wanted to have you kick us off for this walk in the park. But before we let you go, what would you tell a SAGES surgeon who is just out there trying to keep her head above water with her clinical practice? I think for many of us, the system challenges and we already alluded to this us versus them mentality with administration. It can just be absolutely exhausting. What message do you have for them to not only stay engaged, but also how can they be integral in leadership decision making? And I know you shared some of that, but what's your kind of your message for that kind of surgeon who's just really just struggling to keep their head above water clinically?
No, that's a good question, Kevin. I think most surgeons want to just have a great practice. And and that's why they're in surgery. Most surgeons don't want to be a COO. God bless them. They shouldn't. There's no reason to. You don't have to be in the C-suite to be able to do the things you want to do. And it shouldn't take someone getting to the C-suite to be able to do that. Um, as I see it, and I'm giving you a bit of a long-winded answer, but bear with me for a minute. Part of what I love about my job is for the last 31 years, every patient in front of me was my patient. For the last 2 years, every patient that walks in any door in our enterprise is my patient. And every physician working in any one of our 5 hospitals that I'm responsible for, accountable for, is my colleague. And my job is to make sure that they can do their job the way they want and need to do it, and that we're removing as many barriers for them as possible and making it as easy as it can be. I wish I could take them all out. I really do. With a snap of my fingers, that would be brilliant. But we can't. We got to tackle them one at a time and go after it. And we have to be relentless about it. We have to be assiduous about it. And that's how we make it better every time. And it's never fast enough for the surgeon, as you said, who's just trying to take care of her patients, she's got 10 new patients on her clinic schedule for today. She's got 25 post-ops to see. She's still got to do all of her charting and still get home at some point. Maybe if she's in an academic environment, she's thinking about the paper she's trying to write. She's trying to the student that she's trying to mentor and counsel. And she's got 4 cases on the OR schedule for tomorrow and isn't actually getting first case start time because she's only 5 years into her practice, and one of the senior attendings has still got the first case block, and she's going to start those 4 cases at 11:30. But 11:30 is never going to happen because the turnover time is actually 45 minutes, not 25. And the first surgeon said he was going to do that gallbladder in 25 minutes, and it's going to take an hour and a half. That's the reality of that day in the life. So that surgeon's not struggling to keep her head up, but this is just the life that that surgeon is living. And that's a normal day-to-day existence, right? So how does that surgeon identify where those pain points are and be able to articulate them to someone that can help make a difference? Is the question I think you're asking. How does that person who's a member of SAGES, maybe other than that one surgeon, there's another surgeon and he's 10 years out and he's in an fully employed model, and he's being held to account on RVUs alone, and he's struggling to make those RVUs even though he's really busy because the value of each of the cases just dropped by 10%. And now the RVU target becomes harder to hit. He can't make the bonus that he's expecting to make. And that has an impact on whether or not he's going to get a new car next year, because he's also got 3 kids that he's thinking about. And his wife's working as well, and she happens to be a nurse or a physician. All of these are the daily existences, right? It's thinking about, if it's a pain point, how do you articulate the pain point? You don't necessarily have to have a solution, but you need to be able to articulate what the pain point is. If it's not a pain point, it's just about, hey, this is my life. How can it be better? And I think that's an important perspective. Everyone's got pain points, and it's really easy to be reactive to pain points. What's really challenging to do is to rise to the question of how can it just be better? It's not bad, it's not terrible, but how can it be better? And sometimes you don't have time in the day left to think about how it can be better. Sometimes you're just getting through that day in clinic, that next day in the operating room, and you're trying to go from one to the next to the next. But there's always time to think about how it can be better. And whether you're participating in defining how it is, or just articulating to someone that there has to be something better. Help me find it. These are things we can do. But the one kind of core message I have for the average SAGES member, and I'll just offer, being a SAGES member is like being from Lake Wobegon. Everybody is above average. But if you're a SAGES member who is remarkably above average, but what is it that you want to do? I would actually suggest, think about, and I don't mean to sound like a Pollyanna, but gosh, we're really lucky. We get to take care of people. We get to do it with surgery and with medicine and with healing. We get to take care of each other. There are a lot of pain points, but that's a really good place to be. And it's a far, far better place than so many are. And so I think I look at our field, I look at our profession with a tremendous degree of optimism, and a tremendous degree of humility to be able to be given the privilege of doing what we do in the way that we do it. So we can always make things better, and we should always be striving to make things better. Whether that's better in the context of this one patient in front of me today and taking care of them in the best way that I can, in the context of my department and working to make my department better, or in the context of health policy writ large, or anything in between. As surgeons, our job and our raison d'etre is to make things better. So we should look at that as the guiding principle of how we carry about our profession, as well as how we carry out our profession.
Well, I can say is, and I agree with Kevin, and just this was like, we couldn't picture a better way to start season 1 of this podcast. And I think we really, you hit everything out of the park, and we really appreciate the time. So thank you for being our first guest. Thanks for sharing so much of your perspective, taking time, because we know you're slightly busy. So carving time out, we know, is challenging, and the fact that you're willing to sit down and talk to us about this has been great. I'm sure this will be a fantastic resource for our members that we highly encourage all to listen over and over again. There's a lot of nuggets here, so I think they'll have to listen a few times to grab them all. I want to give you a chance, just any final parting gifts of wisdom you'd like to give us on top of everything else you've already shared.
Well, Ross, Julia, Kevin, thank you all very much. I'm actually really privileged to participate in this, and I'm really honored to have been asked to be the first of podcasts. I think this will probably be really effective as a sleeping aid, if nothing else, for people.
Not true at all. Not true at all.
But I think, look, we started this lead up, and obviously, full disclosure, right? I'm a co-chair with Ross on the lead up task force. And so I have to shout out our president, Chris Schlockta, for asking us to do this together. Leading up is a good thing. Leading up works in every aspect of your life, it's not about managing a hierarchy. So I would submit to all of you, to our members and our fellows, leading up is about how you live life. It's not about how you manage your chair or your CEO. It's about how you live your life. You lead up to your family, you lead up to your friends, you lead up to your spouse, you lead up to your community. And that's what we should be thinking about. Leading up, for me, is aspirational. Leading up is what we do to make ourselves better and to make everyone around us better. And so I think that's how I think about using lead up. And so thank you very much for the opportunity to be here with you today.
Thanks so much.
We thank you. We couldn't summarize it any better. And so I guess the only words left for me is to thank everyone who listened, and have a wonderful evening.
Have a great night, everybody.
Have a great night.
Thank you.
Thanks, Paresh.
Thank you, guys.
Thanks. That was great.
And that concludes today's Walk in the Park episode. We hope that today's discussion provides you with both resources and motivation as you lead up in your practices and organizations. Follow us on X, Instagram, or your favorite social media platform @SAGES_updates. Tune in again next time and reach out with any thoughts on how to improve the podcast. We are open to suggestions. See you next time. So, Ross, why did the bicycle fall down?
Why, Kevin?
Because it was too tired.
Thank you for that.